This episode of The Benefit Whisper is brought to you by Route 3 Insurance and Financial Services, where smarter benefits begin. If you're tired of rising healthcare costs and opaque insurance contracts, Route 3 is here to help you take control. They specialize in transparent, employer-driven benefit strategies that protect your people and your bottom line. Ready to break away from the status quo? Visit www.fixmybenefitsnow.com and discover how Route 3 can help you build a plan that actually works for your team and for your budget. Hello and welcome back to the Benefit Whisper. We offer strategic insights for leaders, and I'm your host, Ralph Weber. And today, buckle up. This is going to be a good one. If you've ever suspected that the pharmacy benefits world feels like a magic trick, you didn't ask to see, but it is. You're absolutely right. Behind the curtain, there are layers of pricing games, hidden incentives, and some really bizarre rules that dictate what employers pay and what the employees pay, and they end up filling at the pharmacy counter. So today we're joined by someone who has spent his whole career pulling these curtains wide open. My guest today is Antonio Chacha. He is an expert on pricing, PBMs. He's actually a pricing analyst. He tells the truth. And he's the founder of a nonprofit called 46 Brooklyn Research. He's been a consultant to state attorneys general, Medicaid programs, provider groups, disruptors like Mark Cuban, and he's one of the sharpest minds in the drug pricing ecosystem, if you will. Antonio and his team spent their days turning opaque data into real transparency and turning complicated PBM mechanics into something that the rest of us can understand and, more importantly, challenge. Antonio, welcome to the show. It's so good to have you here.
Great to be with you.
Good. So listen, let's start. If you could tell a little bit about yourself, people that may not know you, tell us about your work, give us the kind of the quick version and, exactly what you do and why it matters so much.
Son of a pharmacist. I wanted to be like Dad when I grew up. Went to Ohio State for pharmacy school and worked as a pharmacy technician at a regional grocery pharmacy up in Cleveland for a few years. I hit organic chemistry and said, maybe I don't want to do pharmacy because organic chemistry was not very fun. I switched to journalism and political science, left college with no plan, and wound up back in the Ohio Pharmacists Association as my second job out of college. In that world, I learned about drug pricing and pharmaceuticals from the biased perspective of pharmacists. Pharmacists want to get paid more for what they do. I think that they deserve to, but that's a matter of opinion. The marketplace did not have the resources available to get pharmacists what they felt they needed to do their job effectively. What was curious was that as pharmacy payments were declining, we saw drug costs spiking on the other end of the transaction, specifically when the Ohio Medicaid program. So when we didn't feel we were getting sufficient answers from the governor's office at the time, we started to download very boring drug pricing data files from the Centers for Medicare and Medicaid Services. And we were able to show how the actual underlying costs of medicines over time were going down, that pharmacy payments were going down, but the cost to the state for those same prescriptions were going up. And so knowing that something was being lost in the middle, we turned over a bunch of data files over to the Columbus Dispatch and Bloomberg News, and voila, all hell broke loose. They found $245 million of hidden spread pricing that pharmacy benefit managers or PBMs were engaging in, where they were essentially paying the pharmacy $5 for a claim, but then billing the state $11 and pocketing the difference. We decided to take all that data and publish it in a nonprofit organization we started in 2018 called 46 Brooklyn Research, where we use publicly available data to teach drug pricing and bridge that gap between misunderstanding and understanding of a complicated market. And then in 2019, we launched a consulting firm called 3 Axis Advisors, where we do work for state attorney generals, state auditors, employers, provider groups, coalitions, industry disruptors, law firms, Medicaid programs, you name it. We are working to unravel the mysteries of our prescription drug transaction.
Wow. Yeah, there are a lot of mysteries. And I love how you put that. The whole healthcare system is built on mysteries. And if you're not out there handing out flashlights, people aren't going to see that. So most of the dysfunction exists underneath the list price, if I understand correctly. And most people really have no idea of the money flows. So let's jump into the big one. There are discounts and net cost and and so on and so forth. So AWP, the average wholesale price. I know that this is basically, it's kind of like the charge master is to medical procedures, if I understand it correctly. But help us to clarify. Is it a fictitious number? Does it have impact? Why is it still the foundation of PBM contracts? And everybody knows it's a scam. Why is it still so prominent?
The reason it's so prominent is it's one of the only drug pricing benchmarks that doesn't have an objective statutory definition at the federal level. The actual manufacturer's list price is wholesale acquisition cost. That's the one that the manufacturer actually sets. In most instances, the AWP, if it is disclosed, it is essentially a corollary of the wholesale acquisition cost, meaning that for brand name drugs, because of litigation years ago, AWP is supposed to have a 1.2 multiplier relationship relative to the wholesale acquisition cost, meaning it is inflated even beyond the manufacturer set list price, but at least it has a tethered relationship, meaning that when WAC goes up, AWP goes up for brand drugs and vice versa. The impact of the settlement around the AWP lawsuits years ago did not extend to generic drugs or to biosimilars. So essentially what you have is an opportunity for what is an objective definition for brand drugs. You could have a very subjective definition for 90% of all transactions, which are generic drugs. And so AWP, even though it has been discovered to be essentially very harmful to the end payer and totally disconnected from any sort of understanding of the actual cost of the drug, despite the fact that it has these flaws and has no objective definition, it remains the cornerstone of PBM guarantees with plan sponsors and pharmacies. And essentially all prescription drug transactions are anchored to this bloated and inflated and disconnected price.
Wow. So you said it's anchored at 1.2. So if the acquisition cost is $100, then AWP would be 120.
That is correct.
Okay. Now, was that for generic, for names? Because you said that one of them was touched, one of them wasn't.
Brand name drugs have the set fixed relationship between WAC and AWP. Generic drugs, it's the Wild West. You can see a drug where the WAC could be $1 and the AWP could be $500, and the next version could be $5 WAC and $10 AWP. There is no rhyme or reason, at least set in stone, for why an AWP versus WAC might be different for a generic drug.
Interesting and distressing. Wow. AWP is fake, but we base billions of dollars in discounts and guarantees on it. But when you get to these big PBMs, the big three, and the big system RFPs, I've participated in one. I've seen it many times. It's usually written by a consultant who actually know better, but I don't know. Maybe they don't want to see it. They evaluate PBMs and actually PPOs for that price on discounts off of AWP. And then magically, the highest priced drug looks like the best deal.
Yeah, for the most part, look, I could point the finger of blame in a lot of directions. The first thing I would say is I think that the system is guilty of copy and paste more than anything. AWP is the bedrock of legacy PBM contracts. And if you are a broker or a current PBM in the marketplace, there's a chicken and egg problem that we've been operating off this old sheet of music. And so people that entered into contracts in the 1980s, 2000s, et cetera, are all operating off of legacy AWP arrangements. So the marketplace has organized itself around the reality that AWP matters, even though it shouldn't. And so when a plan sponsor goes to reprocure, they're often working with a benefits consultant who's been working off the same sheet of music. And they're putting bids out to PBMs who, many of which want to keep the old system in place, some of which just have no choice because that's the sheet of music or that's the test that they're trying to pass. Meanwhile, pharmacies have been making purchases based upon AWP incentives, wholesalers as well, and drug makers have been setting prices with AWPs in mind. So the marketplace has kind of coalesced itself around the reality that AWP matters. And so when you have disruptors in the marketplace, like a Capital RX, which uses a national average drug acquisition cost as a benchmark, or you have Cost Plus Drugs, Mark Cuban's solution, which is a more cost-oriented model. Hell, even CVS Caremark has a new cost-based model, if you want to believe that it's truly based upon their actual costs. Regardless of whether it is or isn't, it is changing what is plugging into an old outlet, right? And so for the most part, it's been very hard to break away from old pricing models because there's so much inertia. There's so much stickiness right, into the way that it's been done. And again, there are so many people who profit off of an AWP linked system. There's little incentive to change.
Okay. That makes sense. What employers need to know is that a 50% discount off of a bad price is still a bad price.
Totally
Is that
agree. I've
yeah.
been using this analogy. If let's say you spend $5 on your cup of coffee every morning, right?
Mhm.
Well, let's say I go to you, Ralph, and I say, Ralph, I know $5 is a little steep. I, a coffee benefit manager, I can help you out. I'm going to get you an 80% discount on your cup of coffee. And it's the same cup of coffee. You won't notice a difference, but I'm going to take over and I'm going to negotiate on your behalf because I have all the size, scale, and sophistication.
Mhm.
And I'm going to give you an 80% discount. And let's say the second I give you that first taste, you're like, all right, I'm going to sign a contract with you and I'm going to let you buy my coffee for the next 3 years. Great. Perfect. So the cup of coffee that you now got an 80% discount off of. So you got your $5 cup of coffee for $1. Great deal, right? Well, now because I'm the coffee benefit manager, I can start putting my thumb on the scale. I can start figuring out which pharmacy or coffee shops to get your coffee at. I could start
Mhm.
essentially seeking out or incentivizing coffee producers to have higher sticker prices for their coffee. And I could start getting kickbacks from coffee bean manufacturers in exchange for favoring certain beans and your cup of coffee versus others. And if I'm the coffee benefit manager, I could actually start my own subsidiary company that's a coffee manufacturer, and I could start setting the list prices of that cup of coffee. So over time, I might be giving you a $100 list price cup of coffee at an 80% discount, which still sounds amazing, but that's a $20 cup of coffee at that point, right? And so you could
Wow.
see how the incentives of the marketplace really work. The PBMs are guaranteeing massive savings, be clear, but they are massive savings off of ridiculous inflated prices. And so we know
Mhm.
that prices are inflated and they're getting more and more inflated over time. So the discount might be substantial, but the actual dollar value of what you're getting might be actually diminishing into a ripoff.
Yeah. I remember years ago, I responded to an RFP for a county in Tennessee. And the RFP said that a large part of what would judge the successful party would be the percent of the discount. So I talked to a local hospital. This was a small county, 8,000 employees plus dependents. So I said, "Do you do any direct contracts?" And they said, "Yeah, sure." And I said, "Okay, now I'm competing for an RFP and it's partly based on the discount. How much discount do you give to the big carriers?" I said, "Yeah, about 50%, 49.52." I said, "Okay. Um, what kind of a discount could I get if we had a direct contract so they'd all come to you?" I said, "What do you want?" And I just threw out a number, a crazy number, Antonio. I said, "How about 75%?" They said, "Yeah, sure." And I thought, wow, I've got this. I'm going to cut their medical costs in half. Right now, they're getting a 50%. I'm going to get them 75. I've got this done. And they said, "Well, listen, one thing that we've got to tell you is right now our charge master, which is the equivalent of the AWP, I guess, in
Mhm.
many ways, is 400% of Medicare. So we'll change that to 800 to give you that 75% discount." Now, if you do the math,
Yay.
70, yeah, so it is totally all a shell game. Now, do you think that there are PBMs that are steering people towards the more profitable drug, profitable for them, not for the plan?
We know that's happening. We put out a report about a couple months ago looking at a company called Qualit Pharmaceuticals. Qualit is owned by Cigna and Express Scripts, Cigna being the
Mhm.
insurer, Express Scripts being the PBM. Now, conventional wisdom would tell you that the PBM is in the interest of low prices, and PBMs will tell you they want low prices for medicines. But now that they own their own drug company and get to set the list prices of these drugs, specifically those AWPs that we were just talking about, it's the perfect opportunity for them to put their money where their mouth is, right? You say
Mhm.
you want low prices. Now you control the pharmacy, the drug, the list price, and the negotiated amount, all because it's under the same umbrella company. It's a
Mhm.
maximum opportunity for control. Well, what we found was that the Qualit Pharmaceuticals products, when compared to the highest prices of the interchangeable products in the marketplace, they're around 83% of relative to the highest price already in the market, which is still a discount, right? But we
Mhm.
already know that some of these prices are way overinflated. So just being essentially 17% less isn't really a significant opportunity, especially when you look at the lowest end of the marketplace. When you compare the AWPs of Qualit's generic drugs to the lowest AWPs in the market for those same products, Collins prices were 33 times higher than the lowest AWP in the marketplace for those drugs. So they can give you all the excuses they want, right? But they know that AWP matters more than anything because their own contracts with plan sponsors and their own pharmacies dictate as
Mhm.
such. So when they're
Mhm.
setting those AWPs, what happens is that they have a protected class of drugs that only their own pharmacy gets to dispense. Those
Mhm.
drugs have high AWPs, which means that their pharmacies will be paid most under those benefit plans. And simultaneously, the plan sponsor will be charged the highest amounts in the marketplace. Although they can also tell the patient under those benefit plans they have to
Mhm.
get their medicines from Express Scripts mail order or specialty pharmacies where those products are on the shelf.
Mm. Yeah, I've seen contracts where they say, if you go to this example, CVS, then the cost of this program will be less. So yeah, I'm not surprised. Real world example, I put in a bid on a PBM contract, sorry, RFP, and they had about 15,000 employees, just under about 26,000 members or so. Now they were spending $72 million a year, which is about $5,000 per employee per year, which I think it's kind of high. When we looked at the numbers, we proposed $28 million in savings. I think they were a little bit too mainstream. They just went from one of the big three to the other. Now, on top of that, it was a really complicated case. So what I'm getting to is numbers. $5,000 per employee per year. In this case, it was, I'm just working out the math around, it was over 2,500 per member per year. Are those high prices,
In
costs?
general, I would say yes.
Wow. Okay. What do you have a benchmark on what
Man,
it?
it really depends. I mean, so much of our work is living in Medicaid, Medicare, commercial,
Mhm. Mhm.
and benefits design is some of the decisions that are made in benefit design can really change some of those numbers significantly. So
Mm.
I always hesitate to give ranges because
Yeah.
not all plan designs are the same.
Right. That makes sense too. That makes sense. How can we sort of how let me phrase it this way, how common is this kind of thing where they just stay with the big ones because they're well known and they're not ready and willing to take a chance and really control their spending?
Oftentimes, it all depends on where you are, where you start,
Mhm.
and where you're going, right? If you're in a bad contract today and you get a slightly worse contract put in front of you and you don't have to do major disruption, you'll take the deal, right?
Right, right.
That happens so often in this business.
Mhm.
We are some of the biggest, I would call us some of the most frictious consultants that you will find in this business, right? We do not have a reputation for playing nice. We hate everybody equally in a lot of ways. And I think that we tend to get a biased view of the market, meaning that if you found us, you
Mhm.
know a lot and you really are probably motivated to change. Even those people can find themselves boxed in, right? They say, "Look,
Mhm.
I don't like what's going on. We want to change.
Mhm.
We want to disrupt." And then all of a sudden, the clock starts running on an RFP or it's making a change and they start running out of time or their current PBM makes a better deal. They sweeten the pot a little bit. Or some executive who has a spouse or a child on a very important drug, they don't want to
Mhm.
change to something else.
Right.
There's a slew of reasons why change doesn't happen, right?
Yeah.
And then you add to the mix that the people that are truly disrupting this industry are operating off different playbooks, right? They're not
Mhm.
doing the legacy AWP based games. They're not leaning in heavy on the GPOs and rebate games. So
Mhm.
you're in essence going to be doing something very different than what the plan sponsor is already used to, what the broker is used to selling, what the broker
Yeah.
might be getting kickbacks or incentive payments to keep feeding, right?
Mhm.
All of those problems coalesce with the reality that drug pricing has become so complicated that the plan sponsor can't figure this out on their own. So they're kind of blind. And so they trust
Mhm.
people like me or you or brokers or whoever.
Mhm.
And
Yeah.
they're told, hey, go use this small PBM, right? Who may be doing things differently. And then
Mhm.
they put it all together and say, look, you know what? I'm not going to get fired for hiring Caremark again, or I'm not going to get fired for
Yeah.
hiring Express Scripts. Everybody's
Mhm.
using them. And so
Right.
they usually just look for a little bit better deal than they got before, even though it may not end up being a better deal.
Yeah. Wow. Yeah, I've seen it way too much in my 30-year career. It doesn't make sense. It's changed, but you're right. I don't think people like change. It's uncomfortable. It's scary, even if it means saving money. And I had Chris Deacon on a few episodes now. And of course, I'm sure you know about what she did in
Oh,
the
she's
state of New
awesome with
Jersey.
Chris.
2 billion. Yeah, she is incredible. So she shows it can be done. It is doable. And, another thing that blows people's minds, and because they don't think this. Most people think that insurance, and you even mentioned it, or PBMs or anything else, want to keep the costs down. So, for example, if I went to General Motors and I said, "Hey guys, listen, I've got this great way to reduce the cost of building a car in half. Okay, we can cut the cost to 50% by doing ABC." They would say, "Wow, that's amazing. That's great. Now we can have a bigger market to sell to. We can sell more cars. We can make more." They would love it. But it seems that in the PBM world and the benefits world in general, that the actual PBMs make more money when employers spend more money. So saving money is financially painful for the PBMs. Is that right?
It depends from a certain point of view, right? The
Mhm,
PBM is very successful at lowering costs, right?
mhm.
But they
Right.
lower costs on their buy side, meaning that they hit the
Ah,
manufacturer for more and more discounts. They're very
right.
successful at doing that. They're very successful at negotiating low reimbursement rates to pharmacies. The rub has
Mhm,
always been the degree with which that they pass those savings on to their clients. Because so much of their model is predicated upon what I would just call shared savings. I think that's the
mhm.
politest way to say it.
Yeah.
It's the higher the prices are, the more bandwidth there is underneath to make money off of quote savings. So
Mm,
PBMs I've referred to as the arsonist and firefighter of high drug prices. Their business model is heavily reliant upon the intrinsic existence of high prices. And so there is very little incentive for them to want to infuse lower priced products in the marketplace because
mhm.
a percentage off a smaller number is a smaller dollar value.
Exactly.
And so, yes, I think that what they want to do is they want to always make sure that they're in line, right? So that they're still, quote, competitive with others in the marketplace.
Mm,
But at the same time, they want to use that ability to kind of set the bar at that reasonable price, but then
mhm,
find ways underneath to push more money in the direction of their vertically integrated company. So, as an example, if I'm a PBM and I'm overpaying for some drugs at some pharmacies, right? I still have to be somewhat competitive in the marketplace. So, how do I balance that out? Well, by overpay the pharmacy for the drugs in the pharmacies that I take ownership of through my company. Well, other pharmacies that are not part of my vertically integrated company, i.e. competitors, I'll settle them with lower reimbursement rates and have it balance out in the aggregate to be a more, market-based price that I might be offering to
right.
my clients.
Wow. Wow. Yeah, it is complicated. So let's move on to kind of another segment, a century of kind of misaligned incentives. Not the last five, but I did a 5-part kind of mini series within the Benefit Whisper, tracing back the last 100 years of healthcare in America, starting in 1929 when the Baylor Teachers Plan was formed, which later became Blue Cross. So one theme keeps coming up again and again. In healthcare in general, we've added administrator after administrator, middleman after middleman. But until healthcare now, I mean, okay, so the Baylor Teachers Plan was formed to solve a problem, liquidity of the hospital and of the patient. Okay. But now healthcare has become a collection business instead of a care business. So, from your point of view, how does PBM dysfunction fit into this greater dysfunction of American healthcare?
I mean, look, I think it's important to balance, what I think are some negative feelings around how the PBM industry operates with the
Mhm.
reality that they're providing significant savings. Now, they heavily incentivize high prices, and so much of the savings is what I would call artificial, but
Right.
it is savings nonetheless. So the question
Mhm.
then is it do we have a PBM problem? Nah, I'd say yes and no, right? The
Mhm.
PBM is working in synergy with other aspects of the drug supply chain that also have a collective interest in high prices. High
Right.
prices serve the entire drug channel very well. The main problem with PBMs that makes them unique among others is that our public policymakers have surrendered marketplace incentives to compete on lowering price. Pharmacy usual and customary prices or their sticker prices are absurd. They're through the roof,
Mhm.
largely not because pharmacies are greedy, but because they're plugging into a system that incentivizes them or fails to
Yeah.
penalize them for setting reasonable lower sticker prices. Manufacturers suffer from the same problem. Government contracts like the Medicaid drug rebate program, the 3B program, Department of Veterans Affairs, Medicare, all of it now incentivizes massive gross to net, which means inflate the price more for more and more discounts. When you add exemptions to federal anti-kickback laws to PBMs in the commercial marketplace, the marketplace is rife with incentives for prices to go sky high, right? So it is totally unreasonable for the patient to walk up to the pharmacy counter and pay the sticker price that is overinflated by the manufacturer, overinflated by the wholesaler, and overinflated by the pharmacy. So then the question becomes, how do you achieve rational pricing in the market? That's where the PBM comes in, right? They are intended to be the friction point to push back against one another drug channel that wants to set the highest prices available in the marketplace. So back to your question is, what is the problem? The problems are the prices, right? Many of these drugs shouldn't need to be bought through insurance. It's like sending the insurance company a bill for when you put gas in your car, right? Of course not. These are cheap commodity products that the marketplace has already been able to make efficient for us. But instead, we have this over-reliance on PBMs to say, I need a PBM to go negotiate for a drug that's $5, right? No, absolutely not, because the PBM is going to want to take their $6, $7, $8 administrative fee. So all of this comes back down to, does public policy and does the marketplace adequately incentivize low prices on their own? Capitalism can work, not for all drugs, right? There are true one-of-one innovator products that manufacturers will take tremendous liberties with, right? But most drugs lend themselves to competitive forces, which means the market can do what PBMs are pretending to be the only ones capable of doing.
Interesting. Wow. You said something about being exempted from a certain markup, or what was it?
Drug companies and PBMs have exemptions to federal anti-kickback laws that allows for drug companies, we call them rebates, right? But if it's an exemption to an anti-kickback law, what does it make it, Ralph? It makes it a kickback, if not for the exemption. So drug companies can pay big dollars. We know there's $350 billion of value underneath the list price of a drug per Drug Channels Institute's numbers, or most recent ones. So you're dealing with an environment where the prices are $350 billion bloated, which means everything is going to be about how you maximize access to those discounts. That sounds okay, right? But now the PBM that you hired to control the drug company is also getting paid by the drug company. So the person you hired to control the drug maker is getting paid by them. It's an obvious conflict of interest. And that idea that you were relying upon the PBM to serve as friction, right, actually starts turning into grease.
Yeah. Wow. Now you said 350 billion. I wonder, 340B pricing, that B doesn't mean billion.
B is literally the section of code where the law was created. B is part of the $350 billion pie, but the B is explicitly referencing the section of federal code that allowed for hospitals and clinics and other covered entities to get the biggest discounts on medicines in the market.
Right. That makes sense. Okay. So let's move on to employers. What should employers actually be doing? So for a lot of our listeners are plan sponsors, CHROs, CFOs, CEOs, and even brokers and TPAs. So if we had to give employers three things that they absolutely must do to stop getting fleeced by this big PBM rebate machine, what would those three things be?
Don't trust anybody and do what you can to take matters into your own hands. I realize not every employer has those resources, but trust me when I say, look, I think we are some of the best consultants you're going to find in this business. We're not without conflicts, right? We're not without bias. Everybody in this business is going to have some sort of conflict of interest or bias. It just is intrinsic throughout. And so from that lens, you're essentially having to trust but verify. Well, most employers don't have the resources, capabilities, sophistication, et cetera, to even do the verification process. Because I always advise people, distrust but verify. Make sure you have an understanding of how the people that you're working with are compensated, from your broker to your consultant to your PBM to your health plan, you name it, right?
Right.
And make sure that you have a transparent accounting of their incentives. Secondly, make sure you have access to your own claims data. You may not have a pharmacy benefits pro on your in-house staff, but it's ultimately numbers in an Excel sheet, right? If your PBM is doing what it's supposed to do, they should be giving you an itemized accounting of everything that you bought, when you bought it, and for what price. I can't tell you the number of times I talk to an employer who says, Tony, our costs are going up. Help us. And I say, okay, give me your contract and give me your data. They don't have the full contract. And then usually they don't have a complete Excel sheet of everything they bought. They might get a PDF file of the report on drug spending. They're not actually getting an itemized accounting. So how are you ever going to be able to have a system of accountability that starts with you, the employer, if you don't even have a right to the information that is ultimately what your consultant, your broker, your PBM, or your health plan are operating off of? The last thing is that, don't assume that the small PBM is worse, and don't assume that the big PBM is worse either. This is a system that rewards size and scale, but it is also a system that is riddled with price discrimination. The reason that the large PBMs or even the small PBMs don't post their prices online is because the reality is they offer different prices to different clients. It's all a profit maximization exercise. How much can I get away with charging somebody who's too stupid to understand what a fair price is? So it should be very straightforward. One of the cool things about one of the things we do is when an employer or plan sponsor wants to know, how much can I save with Mark Cuban Cost Plus Drug Company, right? As an example, we get their data, we run it up against Cost Plus Drugs. We have an exact understanding of what the plan sponsor bought. We know exactly what the cost would have been at Cost Plus Drugs. And because there's only one price at Cost Plus Drugs, I could at least show them what they could have saved, or maybe what would have increased in price, although we've never seen an increase. But I have the data to be able to tell those stories, right? So you have to make sure that you are in a position where you are running the numbers and not just disqualifying people based upon what you assume they're going to do, because everybody is getting a different price, except for these rare instances of Cost Plus Drugs where they have one price for everybody.
Wow. Yeah. That's, and I love what Mark Cuban's doing. It's simple. It makes sense to me, and it's ground up. So I think this is really gold for our listeners. And I keep telling employers time and time again, number one, you can't manage what you can't measure. Okay.
Absolutely.
I think Drucker said that the first, I forget who, but unfortunately, PBMs survive on complexity and opacity. Employers survive when they simplify. So,
No question.
that.
Only thing I would add to that is brokers and consultants benefit from complexity too. Brokers, if the transaction was simple and straightforward, most of what I get hired for doesn't exist anymore.
Right. True. Yep. Excellent point. Wow. This has been really great. So let's move on to the final segment of this episode. All the pricing, the AWP, the MAC, the DIR, all this alphabet soup, all these TLAs, them. Try to help them make sense of the alphabet soup. I'll start with the first one, okay? But then you can hit in, jump in with the rest: the AWP, the MAC, the NADAC, the WAC, the DIR, the GPO rebates. So the first one is the TLA. Do you know what a TLA is?
I've heard of it, but it's not something that I work with. No.
3-letter acronym.
Okay,
Acronym, sorry. So,
here we go.
Okay, why don't you jump in and do the rest?
So AWP, average wholesale price, the most inflated price that you can find. It's I usually refer to it as always what's profitable. If I see it in your contract, I assume that you have problems, period, end of story.
Right.
The MAC, maximum allowable cost. The MAC is ultimately, the idea behind MAC is that for generic drugs that have multiple manufacturers, the PBM is going to, quote, survey the market and say, look, this one's $8, that's $7, that's $6. Well, pharmacies, we know you can buy from anywhere, so we're not going to pay any more than $6 because we know that's available. That sounds like a good thing, right? But the idea of MAC is essentially a subjective setting of price. So just like the PBM can set a fair rate, they could set a low rate, and they could set a really unfair rate on the high side too. So it's a subjective ability for PBMs to invent price. That's not inherently bad if they're adequately incentivized to be efficient. But what we see is that because they have a competing interest in the pharmacy marketplace, because they own their own pharmacies, because they could set multiple MAC lists, meaning they could pay the pharmacy using one MAC list and billing the plan sponsor based upon another one, it becomes funny money. So when you see the word MAC, just think whatever the PBM wants to set.
Right.
NADAC is National Average Drug Acquisition Cost. It's a voluntary survey conducted on behalf of by the Centers for Medicare and Medicaid Services. The
Okay.
idea is to use the benchmark as a means to set the underlying cost of medicines when pharmacies are paid in Medicaid.
Mhm.
So pharmacies essentially report back to CMS what they paid to buy a drug. They take all that data and they shove it into an Excel file and they say, this is the average rate based upon their methods for what it costs pharmacies to actually put the drugs on the shelf.
Okay.
It's not a perfect benchmark because it is voluntary and it often doesn't include off-invoice discounts, but it
Mhm.
represents a good sobriety check when you
Mhm.
see the price of medicine to say, okay, what was I charged relative to the quote NADAC? DIR, direct and indirect remuneration. Every transaction in healthcare isn't a transaction in of itself, meaning that there's usually sub-transactions that fall off of it. So think of it as a gross price that is paid at the
Mhm.
pharmacy. And then retrospectively, there might be concessions that the PBM or health plan might take back from the pharmacy. So let's say the pharmacy's paid $10. They might have a DIR fee 3 months, 6 months, or 7 months after the fact that might
Mhm.
take the actual claim back down to 6 because of a clawback or some sort of reconciliation. So all of these things, these different
Mhm.
acronyms, are different ways to quantify the price of a drug. One of the things that I always laugh at as a drug pricing analyst or a researcher, whatever you want to call me, is that I often get calls from reporters that say, what's the price of this drug? And I often laugh because it's like, okay, well, this is the United States, dude. There's no such thing as the price of a drug because anytime
Right.
you have more than one price for a drug, there's
Yep.
no such thing as the price of a drug. And
Yeah.
all these different acronyms represent different ways that you could quantify the price of a drug based upon certain methods or certain iterations of a drug's flow through the drug channel. So
Yeah.
the benchmarks matter, and then they don't because it may not necessarily reflect what somebody actually is charged.
Yeah. Wow. So it's it all adds to the complexity and the opacity. How about opaque GPO structures?
Yeah, so
There's
years ago
something.
when PBMs got exemptions to federal anti-kickback laws,
Mhm.
PBMs became under scrutiny because while drug companies were getting their lashings in Congress for the inflated prices of drugs, I remember it was Heather Bresch, who was the CEO of Mylan at the time, I think it was in 2016, when there was controversy over the inflated prices of EpiPens.
Mhm.
That was really the first major public hearing where it was revealed, hey, you may not like the list prices of our drugs, but underneath that list price are these massive rebates we're giving in exchange for coverage to
Right.
PBMs. Fast forward to tape, insulin became the next real big bugaboo in Congress. Another
Mhm.
problem where high list prices being offset by massive rebates that were not
Right.
flowing back to patients or employers, who are buying those medicines.
Mhm.
The first Trump administration put a target on rebates and actually proposed repealing the safe harbor that allowed for drug companies and PBMs to engage in these legalized kickbacks. So
Mhm.
shortly after the pressure hit, PBM started architecting these group purchasing organizations. So whereas before the PBM negotiated directly with the drug company, once
Mhm.
the scrutiny started hitting the flow of money between those two entities, the PBM created a GPO who represented their own PBM and others as a means to essentially step in between the transaction, skim money off the top, and then pass the leftovers through. So if there was going to be any policy reforms or any contractual reforms that targeted, quote, PBM rebates, the GPO could essentially stop the flow of money, grab what it wanted, and so policy would only impact the PBM level, but not necessarily the
Oh,
affiliate.
wow. Wow. Okay. Interesting. And of course, everybody assumes that buying in bulk better discounts, and it seems like that's bogus.
I mean, certainly, look, I think that PBMs successfully lower the
Mhm.
net prices. They negotiate lower costs with the manufacturers because of that
Mhm.
scale. But as I
Right.
said earlier, I don't think there's any disputing that PBMs are effective at getting low costs when they want to. It's always been about whether or not they're passing that value back through the system.
Right. Right. Do you know anything about the Ascent Zinc case?
Which one?
Was there more than several?
Yeah. So, I mean, the group purchasing organizations or Zinc and Ascent, right? There are a number
Uh,
of investigations or litigation in this
mhm.
space. There was a recent audit of the Compass Rose Health Plan and the American Postal Workers Union that showed that that the GPOs in those plans were
Mhm.
obfuscating the flow through of drug maker discounts to the plan. You
Mhm.
have the expanded FTC investigation of all the GPOs related to its insulin case and its PBM investigation more broadly. You have
Mhm.
here in our home state of Ohio, where Attorney General Dave Yost has an antitrust lawsuit pending against Ascent.
Mhm.
So, look, years ago, most people couldn't spell PBM, right? So
Yeah.
people are starting to
Yeah.
learn what they are. But just when you think you have the answers, the industry is changing the questions. And
Yeah.
so, just when you think you've gotten familiar with how the PBM operates, you start to
Mhm.
learn that vertical integration can really complicate things. The
Yeah.
PBM may not necessarily be where the action is anymore. The GPO might be where it is.
Right, right. They keep moving it. And what you said a minute ago is what Mark Cuban talks about a lot, in regards to the rebates not getting back to the patient, and that's how he explains that the sickest people are paying for the rest. Because is that an oversimplification, but is that basically the gist of it?
That is literally research right off of our website at 46 Broken. We have
Mhm.
a series called Money from Sick People. And what we do is most
Mhm.
people say, look, these PBMs and these rebates, these are great. They're great discounts. Well, it's not free, right? Like somebody must overpay to generate a rebate. Like when you
Right.
go and get an appliance, right? You go and get an appliance, it has $100 rebate. Well, you pay $900 and then you got to go
Mhm.
home and fill out the form, and then $100 goes back to you.
Right,
That's
right.
not how it
Yeah.
works in the drug channel. In the drug
No.
channel, the sick patient in a high deductible health plan, they walk up
Mhm.
to the pharmacy counter and they see that insulin at $400. Well, that insulin is covered under that patient's benefit plan, but in a high
Uh-huh.
deductible plan, they're not getting an actual benefit at the pharmacy counter. So the patient pays $400. The
Uh-huh.
PBM might get a $300 rebate on it, might share all of it or some of it with the employer. But the
Right.
premise is that the patient had to overpay for the drug to generate a rebate that went somewhere other than the patient's wallet.
Wow.
That is exactly what Cuban is talking about. It is
Yeah.
soaking money from sick people away at the
Mhm.
pharmacy counter to get discounts that don't actually go to the patient who overpaid and generated that rebate in the first place.
Wow. Wow. So indirectly, employers are getting kickbacks from their sick employees' purchases in some cases.
That is absolutely correct. The degree with which they do not have plans that explicitly push through those discounts, right?
Yeah.
Where the patient's in a high deductible health plan where the rebate is generated and it's not passed through. That is
Mhm.
exactly what's happening, is that the sickest patients are providing subsidies back to the overall
Mhm.
plan and plan sponsor.
Right. Wow. Wow. Well, I could go on for a long time. We're getting close to the end of time. I'd love to have you back on another time. There's so much more to talk about. This has been great. You've brought a lot of clarity into a world that absolutely depends on confusion. And you bring that clarity. So that's great. So for our listeners, if you want to understand more about drug pricing, and if you want to understand PBMs, or just want to stop burning money, follow Antonio's work on 46 Brooklyn Research. How can they reach you or follow your work, Antonio?
You just look me up, Antonio Chacha, CIACCIA. There's not many of us out there. And then, you could follow our public facing drug pricing work at 46brooklyn.com. Or if you're interested in hiring us for an investigation, audit, claims review, etc., our professional home is at 3axisadvisors.com.
The number three?
Yes.
Okay, great. So Antonio's nonprofit is a place where transparency isn't just a buzzword, it's the mission. So thank you for being here. And this definitely won't be your last appearance on the Benefit Whisper.
Thanks for having me.
Sure. Thank you. And I'm Ralph Weber. This has been another episode of the Benefit Whisper, where we give the leaders the real truth behind the trends and the courage to fix what's broken. If you enjoyed today's episode, make sure you share it with your CFO, CHRO, HR leader, and share it, save it, subscribe, come back and hear other episodes. If you want to reach me, I can be reached at ralph@thebenefitwhisper.com, or you can visit us at fixmybenefitsnow.com. So until next time, stay curious, stay bold, and fight for true transparency and competition. Thanks, Antonio.
Thank you.
Okay.